You're listening to Soundside. I'm Libby Dankman. GLP-1 drugs that are commonly used to treat diabetes and obesity, like Ozempic and Wegovy, are in big demand. And they're going to be more affordable for many U.S. patients. The Trump administration recently negotiated deals to lower the prices of these drugs. It seems like some details still need to be ironed out. But from the looks of it, many Americans who use Medicare will be able to access GLP-1s at a fraction of their original cost. According to one of the deals, some Medicare patients will be able to get GLP-1s for a $50 copay. So it's safe to assume as costs come down, these drugs are only going to get even more popular. And we wanted to know more about them, like what conversations are doctors having with their patients when it comes to weight loss drugs? And is it safe to get compounded versions of these drugs from a telehealth company, for example? This is the latest Ask a Doctor segment, and we're asking two physicians to answer all of our burning weight loss drug GLP-1 questions. Dr. Mara Gordon is a family physician based in Philadelphia. She also writes about the culture of medicine and is the author of the Real Talk with a Doc column for NPR. And Dr. Scott Hagan is an associate professor of medicine at the University of Washington School of Medicine. He studies obesity, and he's also a primary care doctor. Dr. Gordon and Dr. Hagan, thank you very much, both of you, for being here.
Thank you. It's a pleasure to be here.
Thank you for having us.
So, Dr. Hagan, I have a feeling you've had to explain this once or twice before, but just off the top, humor me. What are the basics here for GLP-1 drugs? How do they work?
So the GLP-1 drugs were first discovered, I think, around the turn of the century as we started to understand better how the body processes nutrients after a meal. And we know that the body makes its own version of GLP-1, of an agonist of the receptor to GLP-1 after meals. And that has a lot of different effects on the body. But when it's used as a treatment for either diabetes or for weight loss, its most important effects would be that it reduces the amount of hunger that the individual experiences. It slows the amount of time it takes food to pass through the intestines. So the same size meal that someone might be accustomed to eating before starting the medicine might make them feel uncomfortably full if they were to have that same meal after starting the medication. And those two effects, the end result being that it can make it easier to control blood sugar, and it can make it much easier for someone trying to achieve weight loss to get those effects.
Dr. Gordon, I want to kind of launch into how people are interacting with these drugs and how they are changing our expectations and the way we interact in the world, the way we move about the world. First of all, I'm just curious, when did you first start having conversations with patients about GLP-1 drugs, and how do those conversations generally go? Do people come in basically deciding they want to be on these drugs, or do you generally bring them up, or how do they come up in conversation in your appointments with patients?
Yeah, that's a great question. So I describe myself as an anti-diet doctor, and the definition I've landed on over the years of talking about this issue and sort of refining what that means is that I don't yell at my patients to lose weight. And you'd be shocked at how radical that is. I think I have been accused of being a quack for such a modest goal, I think.
I just want to note that Dr. Hagan's nodding and kind of laughing, so I'm going to get to you in a second. But sorry, go ahead.
Right. So I mean, this is a really shockingly radical departure from the way that I trained as a primary care physician, which was that it was my duty to point out to my patients that they were fat. And I will note that, I take my cues from a long legacy of fat activists who are sort of reclaiming the word fat and use it as a neutral description of bodies. It's a word you'll hear me use sometimes as typically not a word I'll use to describe a patient unless the patient sort of uses it first. But anyway, I felt like during my training, it was my job to point out to my patients like, hey, have you noticed that maybe you should lose a few pounds? And, obviously everything in society is telling them this, right? And it can often cause a lot of harm for a doctor to sort of pile on. And so my basic practice as an anti-diet doctor right now means that I typically do not initiate conversations about weight loss with my patients. That's not to say just because I typically don't initiate those conversations. Never say never in clinical medicine, because that's the fun of it, is that, every patient is unique, right? And there are some scenarios where I might initiate a conversation about BMI or about body size. But typically I don't sort of recommend that. I will recommend treatment for diabetes, treatment for hypertension. So I try to treat, I do very aggressively and according to evidence-based guidelines, treat my patients for all of these associated diseases, but I try not to focus on body size.
I've read a little bit about your experience as these GLP-1s have been introduced, right? And I think shame is one of the things that you've talked about a lot, and that creates a barrier for people who come into your office. Maybe they do have an elevated body weight, but as you say, bringing that up to them is not a surprise. And so, your approach, your weight neutral approach, is really interesting. I also wonder, as GLP-1s have literally become like an injection that can make a lot of people lose weight. How does that change that approach? Have you noticed more people bringing them up in your practice, or have you changed your approach? Yeah.
Of course, right. So I've been talking about this issue for a couple of years now and writing about it. And when I went on CBS Sunday Morning, which was a wild experience, I got an influx of new patients. And many of them were just sick of being body shamed, didn't want to talk about their body size with a doctor anymore. And I was like, I'm here for it. I'm ready to respect that, right? And part of that calculation for me is, I'm not saying that obesity is good necessarily, right? I mean, it's associated with medical conditions. I think the question is like whether or not I was able to assess for that patient's life, what were the risks of weight loss versus the benefits of weight loss, right? And for some people, there are genuine harms associated with weight loss, right? And genuine harms associated with feeling stigmatized at the doctor's office. So a bunch of patients came in to see me asking for care like that, sort of a size-inclusive anti-diet approach. And then I got a bunch of patients who said, oh, it's so great. You're so nice to people of all body sizes. Can you prescribe me a GLP-1, right? And I was sort of like, wait, were you listening to what I was saying? What's going on? And I realized over time that people were still very eager to lose weight. Many, many people are. And they just didn't want to be yelled at for it, right? They wanted to go to a doctor who was going to make them feel comfortable. And I think when patients come in with that question saying like, hey, I've heard about Zepbound, I want to try it. I always start the conversation by saying like, I'm not going to withhold this medication from you. Radical bodily autonomy is like the core principle of my work as a physician, right? Like the patient gets to decide about their own body, right? So I sort of say that up front, but then I try to ask some gentle follow-up questions, which I'm sure Dr. Hagan does too, right? Like, what are your goals, right? What are you trying to achieve by asking me about a medication like this? What do you want your life to look like? And often those questions get into really emotional, really complicated territory, right? Like I want to keep up with my kids, right? And that's one I get all the time. And I'm not sure that, Zepbound, I don't think that's like an indication for Zepbound, right? I think to keep up with your kids, you got to exercise with your kids. You got to move your body with your kids, right? And I think my goal is to just plant the seeds of some curiosity about goals that they can achieve beyond focusing really narrowly on a number on the scale, right?
Dr. Hagan, I saw you nodding and smiling during Dr. Gordon's conversation about being weight neutral, but also just like finding ways to allow patients to feel safe to talk about these issues. I know that you have discussed getting beyond BMI when we're talking about obesity and issues around health. Do you have patients these days who come in and are asking for GLP-1s? And how do you have those conversations? How has that developed as these drugs have become more ubiquitous?
Those conversations come up all the time. Like every third patient I see, it might, be brought up in some format. And I guess one other kind of venue to mention that commonly is brought up in those discussions is, actually, I am on a GLP-1 medication that I got prescribed through this direct-to-consumer. There are many of these on TV now, and many patients are seeking that care outside of the traditional health system because of a variety of reasons. I think the availability and ease to access care that way, but also they might see that as potentially a less stigmatizing context to engage in that discussion of a company that's, purpose is to identify whether someone might be eligible for the treatments and offer them. So, yeah, I think for many patients, the doctor's office feels like a hostile environment where they've experienced humiliation. And we have now decades of research to show that, in the best case scenario of a clinical trial for lifestyle interventions, the average weight loss at 12 months is maybe in the 3 to 4% range. For most patients, they won't achieve the amount of weight loss that would help them to manage other health conditions. I think docs all along the spectrum are having difficulty trying to square how their practice has been with the availability of these medications that we now know are very, for many patients, I should say, are very effective at managing weight. And there's, of course, not a right answer. I guess my approach generally being that I try to look for the other health conditions that might be associated with weight and have conversations about things that are not weight loss to help manage those conditions. And we know how to answer the question, how would I manage, someone's high cholesterol if they do not have an elevated body weight. So I start at from that approach of weight neutral treatments, but I keep it available as an option for discussion when we're having trouble managing a health condition without weight loss. And then if that's something they're interested in talking about more, I go on to talk not just about the risks of the medication, but I think one sticking point that really has not been well communicated in the kind of lay press and advertisements for these drugs and so forth is, as far as the evidence I've seen, these are indefinite prescriptions, lifelong prescriptions, until we have better evidence to the contrary. And often when patients hear that, they might become more reluctant about it. Am I really signing myself up for this treatment forever? It's not something that when we stop it, that I would expect that weight loss that you've achieved to continue. And so that can be challenging.
Right now, when somebody's prescribed these medications by like their primary care doctor, how much are they paying for them versus like, would a $50 copay make a huge difference for people? What is the effective price right now? Like, what does that picture look like? And I don't know if Dr. Gordon or Dr. Hagan, either one of you guys.
I would just say it would be extremely rare for a patient to have a $50 copay indefinitely for the medications as they're priced currently in almost any different kind of insurance scheme or payment model that is the case currently, unless they're already meeting their annual out-of-pocket max for their medications. So patients are very much subject to like what the formulary plans are and the pharmacy benefits managers for their insurance, and that can make it very difficult to try to price out what their prescription might be now, and impossible to know indefinitely. So personally, I'm glad. I think it can only be taken as good news that this will put downward pressure on the prices, but I remain a bit skeptical about what that might mean 1, 2, 3 years and further down the road for patients for these medications to be affordable.
with regards to the cost, I just wanted to add that, I practice in a low income community of color. The majority of my patients are publicly insured. And cost is just a nightmare. I mean, what it means is that these medications are essentially inaccessible to the vast majority of my patients, right? It's really about health equity, right? It's not just about like, I might have to work an extra $500 in a month into my monthly budget so that I can, look hot for this event, right? Like it's really not about that. It's about racism and poverty.
As these GLP-1 drugs become more popular as cosmetic aids, as, something people kind of think of as maybe similar to Botox or other types of cosmetic procedures that you would do ahead of a big event or wedding. What are you watching for? What are you concerned about with that evolution of our relationship with these drugs?
Yeah, well, I'll share the story of one of the first patients that I prescribed Ozempic for. He is a young man who lived in a pretty large body. And he came to me saying, I've heard about these meds. Can I try one? Right. And he was privately insured, which most of my patients are not. And he was able to get it covered. This, I think, was in like 2022, maybe. And he lost a fair amount of weight. I would say maybe like 20% of his body weight. And he was grappling with a lot. And I asked him point blank the other day, did you feel like this was a success? And he said yes. But it really unmasked a lot of depression. He had to grapple with how people treated him differently now that he was sort of existing in a differently sized body. And he realized that he had a lot of other stuff going on in his life that he had sort of blamed on his weight. But now that he had lost weight, he had to contend with. And I think that culturally that needs to happen too, right? That our society is just so obsessed with thinness that, we forget to ask ourselves, like, what would happen if a lot of people lose a lot of weight? And we still have a hierarchy of bodies, right?
I'm just thinking, as these things, again, become cosmetically similar to getting your hair done or getting a, little thing done on your face, what will you be watching for, Dr. Hagan? Like, what does that bring up for you, and how will that impact the way that you interact with patients?
I don't have a good answer. I mean, like, who am I to decide to try to, if I'm not making a recommendation for a GLP-1 to help manage a medical condition that I think it will, and instead, it's a situation where a patient has elevated body weight by the criteria that the FDA label says it does, and would meet the authorization criteria and so forth. For me to try to say I'm not going to do that because I can't subscribe to that sort of diet culture that underlies that. I don't think I can do that. I think I could say. I think my approach in those situations would be that, yes, I can prescribe this medication. We can monitor for the side effects and the safety of it carefully, and that it is the patient's decision. But I acknowledge that, underlying that are these cultural forces, a diet culture that has long existed, that GLP-1s will not rid ourselves of. In fact, it may only accelerate them. I think there's this separate more clear-cut situation of someone with without extra adiposity or an elevated BMI who's seeking a prescription, where this is now commonly offered in different sort of med spas and these cosmetic companies that have a brick and mortar office that have done other other cosmetic offerings, and are now, in addition to that, they have a prescriber in their office that will offer GLP-1 therapy, sort of off-label and without consideration to other health problems or BMI and so forth. I think that is like a dangerous precedent, both for prescribing it to folks where, the risks of malnutrition and going to a dangerously low body weight and things like this are substantial. and that there might be other health problems that those kinds of direct-to-consumer or med spas or these other kind of outside of a traditional health system prescribers won't be aware of their other health conditions or be in a good position to manage them.
Yeah. Just really quick in a follow-up there, Dr. Hagan, do you have similar concerns when it comes to these compounding pharmacies? I mean, places where they're offering the compounding version of the drugs. They're not approved by the FDA. Do you have a similar set of concerns about that type of setup? And do you think that they're safe for people?
I could not with confidence say that those are safe for people. And some of these compounding pharmacies will add, the way that they package this, the GLP-1 in the solution might include dangerous chemicals, different salts that could be riskier. And sometimes they add other stuff that is of very thin evidence or none at all, like B12. They do these like combination treatments and things like this that, I just cannot trust. I think there was a valid indication before when there was a shortage of the GLP-1s that the FDA had declared that in those situations, reputable pharmacies could compound the medications to make them available to patients. That has now gone away with the lack of a declared shortage for semaglutide and tirzepatide. And so I think the persisting pharmacies that are doing these compounding are probably less likely to be the reputable pharmacies that I would trust to, and the companies that are prescribing these medications. I think the combination of both of those make me extra reluctant to these. But I understand it from the patient standpoint of like, this is a path to getting a cheaper prescription for me. And so I'm going to do what I can to get a medication that I think that may help me at an affordable price.
Dr. Gordon, we've brought up a lot of different issues here. I think that, the idea of the body positivity movement, which I think a lot of people would say had gained a lot of momentum, especially in the mid-2010s or so, and now is facing this new set of questions as GLP-1 drugs become more ubiquitous. That's one issue. The issue of the cosmetic use of Ozempic and other GLP-1s is a related issue. The costs that we've talked about here overlays all of that, and access and class and income and race. What's a final thought for you as we've been talking about all these things that, either you are watching for as this all develops and trickles out into our society, or things in your practice that you are watching for that you want to kind of leave people with as a final thought? I know that's very open-ended.
Yeah. Well, thank you for asking, and thank you so much for having me. And I think the question I get about body positivity from a lot of people, from my students, from patients, from strangers on the internet, is sort of this question that, is treating your body with kindness, is treating your body gently, somehow like giving up on the pursuit of health? Or if you want your body to be smaller, is that somehow a betrayal of solidarity with body size diversity? And I like the term body justice. I have a nod to Black feminists who coined the term reproductive justice, where I sort of draw inspiration from. I think body justice for me sort of says, okay, we can want our bodies to be healthy, but we can also treat our bodies with a sense of care and kindness and respect. And exactly how this plays out for each individual patient in the GLP-1 era is a really personal question. But I sort of see it as my job as a primary care physician, as a partner to my patients, to ask questions that I hope will plant some seeds of curiosity about this. Like, what would it feel like to, be kind to my body? What does that look like? And I think it can look like a lot of things. I think it can look like taking a GLP-1, and it can look like saying, hey, actually, I'd rather be 10 pounds heavier than feel nauseated all the time, and I'd rather enjoy food, right? And I think both of those are valid responses to that question of how do we seek justice for our bodies.
Dr. Mara Gordon is a family physician based in Philadelphia. She writes about the culture of medicine for NPR and other outlets. She has a Substack called Your Doctor Friend. Thank you very much, Dr. Gordon, for being here. I appreciate it.
Thank you so much. Such an important conversation.
And Dr. Scott Hagan is an associate professor of medicine at the University of Washington School of Medicine. And he also is a primary care physician. Dr. Hagan, thank you.
Appreciate the conversation. Thank you very much.
That's a wrap on our latest Ask a Doctor segment, where we ask medical professionals to help us make sense of health stories in the headlines. I do have an ask now for our audience, especially nurses and doctors out there. For our next Ask a Doctor, we want to talk about the trend of people turning to AI for medical advice. And we want to talk about how much AI tools like ChatGPT are coming up in your conversations with patients. And for listeners/patients, if you use AI tools for medical advice, we want to hear from you, whether you think they're useful, what you've used them for, what kind of medical questions you've asked ChatGPT. You don't need to get too detailed. Email us with your thoughts on how you've interacted with AI when it comes to your health. That's at soundside@kuow.org, or leave us a voicemail at 206-221-3213. You might hear your voice on the show. Thanks for listening to Soundside. Don't forget you can listen live on KUOW 94.9 Seattle at noon and 8 p.m. Monday through Thursday, or anytime right here online at KUOW.org, or of course on your favorite podcast app.